Hello, everyone. My name is Tom Tadros. I'm one of the electrophysiologists at Brigham and Women's Hospital in Boston, Massachusetts. I'm going to be talking about anticoagulation for AFib in adult congenital heart disease. I have no disclosures. I want to discuss these objectives. Number one, what is the risk of stroke and what are the predictors of stroke in patients with ACHD and AFib? What are the guideline recommendations for stroke prophylaxis? What are the indications for use of NOACs in place of vitamin K antagonists? I want to talk about anticoagulation management in specific scenarios, and also discuss the utility of measuring plasma NOAC concentrations. So to start with, what are the stroke predictors in patients with AFib? This Swedish National Registry has more than 88,000 patients with adult congenital heart disease and follow them over time and compare them to controls without congenital heart disease. And what they found was that there was a 5-fold higher increased risk of ischemic stroke in patients with CHD compared to those who don't. They also found that the age at which these strokes happen is earlier than compared to the control population, so that by age 50, there was a more than 5% risk of ischemic stroke. This other large registry with more than 29,000 patients with adult congenital heart disease looked at what were the strongest predictors of ischemic stroke in this population. And they found that heart failure, particularly in the younger adult age group compared to older adults, as well as diabetes and recent myocardial infarction, were the three strongest predictors of ischemic stroke. Of this population, 15% had atrial arrhythmia. And within that group, what they found was that atrial arrhythmia more than doubled the risk of having an embolic event compared to those without AFib. The TACTIC study was a retrospective study with 480 patients with various degrees of complexity of congenital heart disease, and followed them for a primary outcome of thromboembolic event. And they were followed for a mean of 11 years. And granted, this is not a natural history study because most of these patients were on some type of blood thinner. More than half of them were on oral anticoagulation, and about 38% of them were on antiplatelet therapy. And they looked at multivariable Cox regression analysis to find what factors correlated with risk of thromboembolic event. And they found that the only factor that correlated significantly was complexity of congenital heart disease. So those with mild congenital heart disease had no thromboembolic events over the follow-up, whereas those with moderate to severe complexity of congenital heart disease had a much higher risk of having a thromboembolic event. They also looked at factors that were independently associated with bleeding in this population, and what they found was that use of oral anticoagulation was associated with bleeding, as expected, and that the Hasbled score also did correlate with the risk of bleeding. And so what are the guideline recommendations for stroke prophylaxis? So the 2020 European Society of Cardiology Guidelines for Management of Adult Congenital Heart Disease state that if you have mild congenital heart disease, that the CHADS-VAS score can be used to guide a decision regarding whether or not to use oral anticoagulation. If you have moderate or severe congenital heart disease, oral anticoagulation is recommended regardless of your CHADS-VAS score. The guideline recommendations also note that NOACs seem similarly safe and effective in the absence of mechanical valves or severe mitral stenosis. And so let's look at use of NOACs in place of vitamin K antagonists. First of all, who does well on warfarin? So this study was a retrospective analysis of more than 200 patients with congenital heart disease, followed for a median of 6.8 years. And they looked at factors that correlated with good time in therapeutic range, meaning a therapeutic INR greater than 65% of the time. And what they found was that longer duration of treatment, male sex, lack of heart failure, and older age all correlated with good time in therapeutic range. And that is as expected, as we know that in the adult congenital heart failure population, that menorrhagia is a very common occurrence that would result in interruption of warfarin as well as NOACs to explain these findings. So are NOACs safe? There are two main studies that were used to guide a decision regarding use of NOACs in this population. The first one is called the NOTE registry. This was a prospective cohort study with 530 patients with congenital heart disease, 85% of which had moderate to severe CHD, and more than 90% were taking oral anticoagulation for AFib. Those with mechanical valves or significant mitral stenosis were excluded from this study. The primary efficacy endpoint was thromboembolic event, and the primary safety endpoint was major bleeding. And what they found that over kind of a median of 1 year, that the annual risk of thromboembolic event was about 1%, and the annual risk of major bleeding was also only about 1% per year. So from this, it appeared that the NOACs appeared to be quite safe in this population. Now, within this study, 150 of these patients had previously been on warfarin before they were on a NOAC. So within that group of 150 patients, they looked at the time that the patients were on warfarin compared to the time that they were on their NOAC, and looked at thromboembolic events as well as major bleeding. And what they found was that there was no significant difference in either thromboembolic event or major bleeding in these patients when they were on warfarin compared to when they were subsequently on NOACs. To look at another study, this was a prospective observational study, smaller than the previous one in that it had only 75 patients with congenital heart disease, half of which had moderate to severe complexity. And they were followed for a mean of 12 months, and they were on various different NOACs, and 3/4 of them were anticoagulated for AFib. And the mean CHA2DS2-VASc score was greater than or equal to 2 in about 30% of them. And they found that there were 0 thromboembolic events and 0 major bleeding events within this mean follow-up of 12 months. You can see minor bleeding was about 47%. But from these two studies, the guidelines recommendations do state that NOACs seem to be relatively safe compared to warfarin in this patient population. So let's look at anticoagulation management in specific scenarios. First of all, in women of reproductive age. So we know that warfarin can cross the placenta, it can be teratogenic, and it can cause fetal bleeding. So warfarin should be avoided during attempted conception, as well as during the first trimester of pregnancy. Regarding NOACs, there are insufficient data regarding safety in pregnancy in this population. Thus, NOACs are not recommended during attempted conception, and they're not recommended during pregnancy. Low molecular weight heparin is recommended for attempted conception or the first trimester of pregnancy. And it is important in your patient cohorts to discuss contraception to avoid unintended pregnancy during which the early periods they might be on oral anticoagulation that could be teratogenic. Preferably a non-estrogen-based contraception is preferred to avoid increased risk of thrombus formation. There was one study looking at rivaroxaban compared to warfarin and found that the rivaroxaban did have a longer menstrual bleeding time, increased risk for menopause-related interventions, and more interruption of OAC compared to warfarin. So of the NOACs, rivaroxaban may be considered as kind of an alternative choice compared to other NOACs. So what about use of NOACs around the time of ablation? This was a retrospective analysis of 368 ablation procedures with various degrees of complexity of congenital heart disease. And they looked at patients who were on uninterrupted warfarin versus uninterrupted NOACs. And what they found that there were no thromboembolic events in these patients, and that the risk of vascular or major bleeding complications were not significantly different on those who were on the NOACs compared to those who were on warfarin. So it does appear to be safe to use NOACs around time of ablation. And what about for cardioversion within 48 hours? If the patient has moderate or complex congenital heart disease, it is important to either get a TEE or anticoagulate for at least 3 weeks prior to proceeding with cardioversion in this patient population. And for drug interactions, we know that the NOACs are metabolized by CYP3A4 as well as P-glycoprotein, so that there are some interactions that we should be aware of. And the agents that we typically or commonly use in our patient population, including diltiazem, verapamil, and amiodarone can increase plasma concentrations of NOACs and can increase risk of bleeding. So that should be taken into account when deciding on dosing of NOACs. And the 2018 guidelines on use of NOACs in this patient population can be helpful for guiding a decision regarding dosing. Hepatic dysfunction, this is particularly important among our Fontan patients. Advanced liver disease can be both prothrombotic and can cause increased risk of bleeding. So it can be quite complex to manage oral anticoagulation in this patient population. Liver dysfunction can also affect hepatic clearance and drug metabolism. A use of warfarin can be challenging because intrinsic INR levels can be elevated and may not necessarily represent proper oral anticoagulation. There are not really available data on kind of NOACs in the major drug trials for use of NOACs, but NOACs do not appear to be hepatotoxic. So the guideline recommendations state that if you have mild liver disease, it is okay to use NOACs without dose reduction. If you have advanced liver disease, NOACs are contraindicated. And if you have moderate liver disease, you can use NOACs with caution. So in the adult population, we have data on dose adjustments based upon age greater than 80 years old, body weight less than 60 kilograms, or renal dysfunction, that if you have 2 out of these 3, that you should consider dose reduction of NOAC. And the adult congenital heart disease population, there are limited data. So it can be quite challenging to know when to reduce doses. So that raises a question about whether there's any utility to measuring plasma NOAC concentrations. And the short answer is that we don't know. There are not enough data to decide whether or not to measure NOAC concentrations. One study that is quite interesting is the ENGAGE-AF-TIMI 48 trial that included nearly 7,000 patients with atrial fibrillation who are randomized 1:1:1 to either warfarin, edoxaban high dose 60 milligrams, or edoxaban low dose 30 milligrams. And whether they were randomized to the higher or lower dose edoxaban, dose adjustments were allowed for certain indications such as reduced renal function, body weight less than 60 kilograms, or medication interactions with P-glycoprotein substrate. And they looked for endpoints of stroke as well as major bleeding over a median follow-up of 2.8 years. Now, there are a lot of interesting data from this study, but kind of the main thing I want to bring out from this is that these are concentrations, plasma edoxaban concentration on the x-axis versus trough anti-factor 10A activity on the y-axis. And if you look at the groups, again, 30 milligrams here, same dose, 30 milligrams here, but this group were the ones that were randomized to the higher dose, but received a dose reduction based upon either renal dysfunction or low body weight or medication interaction. And this group were assigned to the lower dose edoxaban, but did not have dose adjustment, meaning they did not have significant renal dysfunction or other factor that would require dose reduction. So same dose, 30 milligrams, but the patients who met the criteria for dose reduction based upon either renal dysfunction or some other interaction had a much higher rate of thromboembolic events as well as major bleeding complication compared to those in the same dose who were just randomly assigned to the 30 milligram dose. So the take-home point from that is that there are certain clinical factors that have effects on the outcomes, including both stroke and bleeding, that may not be reflected by drug concentration alone. Thus, just relying on a drug concentration may not be effective for knowing what the best thing to do is in terms of dosing. Also from this study, this looked at trough edoxaban concentration, and you can see that from kind of undetectable drug concentration up to the highest detectable concentration, that if you look at intracranial hemorrhage, which is demonstrated on this kind of green bar here, that the risk of intracranial hemorrhage is relatively low no matter what your drug concentration is, and that is quite reassuring. If you look at stroke, you can see that there's a steady decline in stroke risk as you get to the higher concentrations of the edoxaban. But if you look at major bleeding, that there's a much more kind of rapid increase in bleeding risk as you get to the higher drug concentrations. And so, it is unclear what is the therapeutic range here for drug concentration, but you could see at no matter what the drug concentration, the probability of having a major bleeding event is significantly higher than having a stroke or systemic embolism event. And so the Boston Children's Group actually is measuring NOAC plasma concentrations in all of their pediatric population on NOACs. And it has been quite helpful, especially in the kind of wide range of body weights of these patients that have affected the kind of initial drug dose that is chosen, that there was a wide range of drug concentrations across this pediatric population. And it has been quite helpful on a patient-by-patient basis to modify doses and kind of minimize menorrhagia and other kind of bleeding complications that can be associated with NOACs. And so the 2018 EHRA guidelines on use of NOACs for AFib do know that measuring plasma NOAC concentrations can be helpful in some situations. For example, just having a baseline peak and trough to guide your patient's dosing on a patient-by-patient basis, and prior to an emergency operation or emergency use of thrombolytics in the case of acute ischemic stroke, that measuring levels might be helpful in guiding clinical decisions. So in summary, congenital heart disease patients have a 5-fold higher lifetime risk of ischemic stroke. The CHADS-VASc and HAS-BLED scores have not been validated in the adult congenital heart disease population, so that these should be used in combination with individual risk assessment. For simple congenital heart disease, the CHADS-VASc score should be utilized to guide a decision regarding oral anticoagulation. For those with moderate to severe complexity of congenital heart disease, oral anticoagulation is recommended regardless. Although warfarin is traditionally recommended, NOACs do seem to be safe in this patient population based on limited studies, and that measuring plasma NOAC concentrations may be helpful in specific patient scenarios. So with that, I thank you very much for your attention.